ahead and get started? All right. So good morning. My name is Dr. LaShanta Rice. I am Assistant Professor in Psychiatry and Behavioral Science, and I am affiliated with the Cancer Control Program here in the Hollins Cancer Center. And today we have the pleasure of hearing about developing and testing of a palliative care navigation intervention for rural cancer patients in India. This will be a dual presentation presented by Dr. Cartmell and Dr. Qanungo. And so just to give you a brief introduction about their background, Dr. Cartmell is an assistant professor in the College of Nursing here at the Medical University of South Carolina, and so is Dr. Qanungo. Dr. Qanungo is Associate Director of the Telehealth Program, and as I mentioned, this is a dual project that they're currently working on through the Center for Global Health to develop and test patient navigation intervention. And the goal, of course, is to improve delivery of palliative care services for cancer patients, and they'll be sharing about that project today. So furthermore about Dr. Cartmell is she received her Master's of Public Health degree from Emory University, Rollins School of Public Health, and her doctoral degree in Health and Rehabilitation Services, here at the Medical University of South Carolina. Prior to joining the College of Nursing in July 2013, she worked in the Hollins Cancer Center as a cancer prevention research project manager for 7 years, and at the public health grassroots level in Georgia as a regional epidemiologist for 6 years. Dr. Cartmell has served on several projects and has several underway. One focuses on the AHRQ-funded R21, and it's a study to evaluate the effects of MUSC quits tobacco cessation services at healthcare utilization and cost outcomes. She recently carried out an NCI-funded evaluation of barriers, facilitations, and potential strategies for improving HPV in South Carolina. So as I mentioned today, this project will focus on looking at interventions on a project that they're working towards in India. And again, this is a dual PI project. So without further ado, Dr. Cartmell and Dr. Qanungo.
Hello, my name is Dr. Qanungo. My name is Suparna, and I am, my interest is really in global health. Both myself and Kathleen are really passionate about the global health projects. So we have plans of multiple global health projects in the future, but today we are going to talk about this one, which we have in our way and which we actually got funded for. Just to give you a small introduction of myself, I was a basic scientist by training, and I actually worked in the drug discovery here in MUSC before, prior to moving into College of Nursing. But then I transitioned into public health, and now I'm an assistant professor in the College of Nursing. So one of the things for my move to public health was I really wanted to work with people. And that's also the driving force behind all of these projects. Here, we not only work with people here, but also globally. And that has been a big passion for myself as well as Kathleen. Okay.
You may have to scroll down. It's up to you.
Who's that? Here, yeah. Okay. So how did this collaboration start? It really started with just a very informal phone call. I did a phone call to the collaborators in India, just talking and discussing about various things. And in that phone call, I asked, "What's your greatest need?" And they talked about various needs because they have, they had basic science research that they wanted to do. They also had, implementing EMR system, and but then they quickly told me that palliative care was one of their biggest needs, since they are not being able to reach out to the people in the rural India. So of course, Kathleen and I jumped on board, and we applied for the Center for Global Health grant and got funded for it. So our collaborators back there are Dr. Gautam Bhattacharya and Rakesh Roy and Ms. Rekha Chaudhary, and they are just wonderful people to work with. As all of you know, in the U.S., the access to care, of course, is an issue in very, very rural areas, but not everywhere. Like here, at least you have an emergency vehicle when you are sick, an emergency vehicle that will take you to the hospital, and you can get treated. Versus in India, you don't have to go too rural to face in a situation like this, where if you are really lucky, you get a bike taxi to take you to the nearest bus or train station, and there you have to get loaded in this, this overcrowded vehicles, and then finally when you appear to the clinic, you have to stand in long lines to get yourself to the physician. So access to care has been a real issue in India. And you don't really have to be, I want to make this point, you don't have to be very rural to do this. You can live just in the outskirts of the city, or even in a little bit far away from the cancer center to be in a situation like this. Come on. So the need is rural India's limited access to care, which is amplified by poverty, the excessive traffic, and their distance from the nearest center. So cancer patients, most of the time, by the time they actually appear to the cancer center, they are in the very late stages, and at that time, the providers, all they can provide is pain and symptom support. And so palliative care has been emerging as a great need in India. The common cancers that need palliative care services, as we were told in this cancer center, was head and neck and lung. These were the topmost, and then followed by GU, GI, breast, and sarcoma. And so this is the project setting. This is the cancer center. The cancer center itself is not that rural. It is actually pretty well established, but it caters to the rural and impoverished population. And it is a leading cancer center in India, in the eastern part of India, and it is recognized by the World Health Organization. So these are their facilities. They have diagnostic and therapeutic facilities. They provide support group services free of charge, and they have an outpatient department which offers free services to 40,000 patients per year. And apart from that, they also have a research infrastructure, which is Indian Council of Medical Research approved, and they conduct clinical and basic science research. And one good thing that we found while working with them is that they have an ethical board, and as all of you know, when you have to do a research with an outside, out of here, like in a different country, it becomes a big challenge to get your IRB approved. And so having an ethical board there really helped us. And so we visited this cancer center on 2 occasions. The first trip was made in November by myself and Kathleen, and that was for this particular project. And then after that, I visited with 6 of our nursing students for a learning trip. That was in December. So these are some of the pictures taken from our trips. This is their pediatric oncology hospital dorms with our nursing students in there. This is their palliative chemotherapy outpatient dorm. And this is their surgical unit, and these are all our students. So one of the other things that I would like to mention here is you see their chemotherapy, the palliative chemotherapy outpatient dorm. Here, as the beds are lined up, the physicians, the nurses are also in the same room, which I thought was a little bit different from here. Plus, when we asked the patients, they thought that that was very helpful for them because they can see their doctors and their nurses right in front of them when they have pain or they need any help. And with that, I'm going to turn it over to Kathleen to start talking about the research. And then in the end, we would like to go with a discussion.
This is the hardest part. Okay, so first off, I want to show you guys my new outfit that I bought from India. I had fun doing a little shopping there. Let me just make sure this is Okay, all right, it's moving. So anyway, I'm really excited about this project and getting a chance to tell you all about it. So I figure we should probably start by first just going over what is palliative care for anybody who might not know. So we use the World Health Organization's definition because we're using some of their tools and it seemed appropriate. So palliative care is just an approach that improves quality of life of patients and their families that face problems associated with life-threatening illness through prevention and relief of suffering by means of early identification, assessment, and treatment of pain and other types of problems. And it ranges from the physical to the psychosocial to the spiritual needs. So that's our definition. Basically, the global need for palliative care is huge. There are about 20 million people living in the developing countries, but about only 10% of people get access to any kind of palliative care. And what we found is that there are very few models, really no models with solid evidence behind them for delivering palliative care in low-resource countries. Most of the models are pretty much based on programs that were developed with lots of resources we have here in the U.S. and in the U.K. So there's a real need there. And secondly, India has very high rates of poverty, and about 2/3 of the people live in rural areas, which means that it's really hard for them to get into the cancer center to receive care. So obviously, with these things combined, a home-based palliative care project, and we chose to use a navigation model, seems like it would be very promising. So it's interesting, back when I did my Master of Public Health work, patient navigation is nothing new. It really came out of places like India and South America, where it tended to be used a lot to help deliver maternal and child health programs. For instance, oral rehydration to keep children from dying from dehydration, immunizations, to get services to people that are really out in rural areas anyway. And there are a lot of different names for navigators, which kind of gets confusing sometimes, but patient navigation, lay health advisor, community health worker, case managers. But the one thing these services all have in common is that they help link patients with some sort of health services that they really need access to. So in the U.S., here at the Cancer Center, we use patient navigation a lot to try to improve especially the timeliness and completeness of things like cervical and breast cancer screening and diagnostics, and help people get through treatment. And there's really solid evidence that navigation models can greatly improve timeliness and completion of cancer treatment, and also have some effects on outcomes as well. So that being said, we thought that patient navigation is a model that could really help ensure that patients in rural areas are able to get really high quality palliative services that they otherwise wouldn't be able to access. So the other kind of interesting thing about the project, about the time we started looking at doing this, the World Health Organization had just made a big focus on palliative care, and they had put out the World Health Organization Toolkit for community-based palliative care. This is such a nice resource. I think it's in 14 languages, including Bengali, the language spoken in Calcutta where we're working. And it's basically designed so that people in their own communities can take care of patients in their area. It takes the medicalization out of palliative care and says anybody can help do things like control pain and help link patients to the resources they need. And we think in India this approach could work really well, because what we found is there are so very few oncologists for such a very large population. Basically, the toolkit contains really very elegant, simple, basic tools for delivering palliative care. It uses like visual scales for assessing pain and other types of symptoms, very simple guidance on how to communicate with patients and their families about services they need, and about just different issues that come around upon the end of life. Guidance for how you help obtain resources for patients, and then just like pretty much all the forms that you need to help monitor and take care of the patient in their home. So the toolkit was first developed in a couple of African countries that included Tanzania and I think maybe Uganda. And basically all the research that's out there now are really process outcomes for the most part. They look to see how they delivered it, but nobody's really assessed kind of the effectiveness of the intervention, and there's been a big call for more research in this area. So we thought this would be a great opportunity developing our intervention that builds on the World Health Organization toolkit. And these are just kind of the chapters in the toolkit, kind of goes over what is palliative care, basically how community members can do it, building a team to help the patient. And you can take a look through here and scroll down. At the end, they've got the toolkit with all the different tools and other types of resources. So currently, I really love the model that they use at the Suraj Gupta Cancer Center. It's really wonderful. It's pretty much based on, though, on cutting-edge approaches that come from the U.S. and the U.K., where basically they take out a vehicle from the cancer center that includes an oncologist, a social worker, a nurse, maybe a clinical psychologist, different people, and it requires a lot of resources to do this. And I think that is great in that smaller 21-kilometer radius where they are able to serve their patients. But they said we can't really go any further than that with the resources that we have. So they were looking for something a little more labor-intensive and simpler that they could use out to help patients in the rural areas. Basically, the intervention model is simply to identify individuals who would work as a navigator in each of the rural communities outside of this part of Calcutta. So we would use the navigator who would regularly meet with the patient and serve as a link back to the cancer center. This is basically a mixed method study. The purpose to improve palliative care for patients outside of rural Calcutta. We've carried out AIM-1 already, which in November we went and did 22 interviews with folks from the Cancer Center that I'll tell you more about. Now we're working on developing the palliative care navigation model. And then the third aim will be to test the feasibility of the protocol with just a very small number of patients and navigators. So for AIM-1, the key informant interviews were really amazing. We talked with the oncologists, social workers, clinical psychologists, lay navigators, patients, many of whom were in their home environment, which was really, really great to see kind of how care is delivered in the homes. And that was really interesting. So we basically wanted to know, how is palliative care basically delivered at this point? And for the most part, in the rural areas, when a patient has cancer, they just have to send, like a proxy, a family member to the cancer center to get some medications to handle pain medicine. And that's about the reach of the services that they're able to access, which is fairly limited. We also looked at barriers to delivering palliative care. And then really trying to get a sense of, well, what should the palliative care navigation intervention look like? So I'll go over some of the preliminary findings from the interviews. So the barriers, a couple of them were very unique. So Suparna touched on this already, but basically the cancer center is the last place that people with cancer tend to go. They tend to first go to the local healers and shamans. They might go to kind of the rural doctors. Some of them talked about taking a spiritual journey just to hope that they would heal and everything. But when their health starts really going downhill is when they tend to go and see the folks at the cancer center. So that one thing means that curative treatment is a lot harder to do, but it also makes palliative care services incredibly needed at this point. So the other thing that was incredibly interesting was just such a lack of knowledge about the patient's cancer. So just to give you a few examples, there was, one patient who was in a lot of pain, and he'd basically been using morphine, and he stopped taking it because he was afraid he was going to reach a threshold where it wouldn't help him anymore. He was having constipation, didn't realize that there were also meds that could help relieve some of that, and so that could really have helped improve his quality of care, quality of life. And then also, there was this lady that Suparna and I both just really loved a lot. And she said, the worst thing about having cancer was that she lives in a very small 2-room house. And she's like, my grandkids can't come over and sleep in the bed and hang out with me in the bed because, I'm contagious. And she wasn't contagious. It's cancer. And we tried to explain that to her, and I still wonder now if she really got that message and she's able to enjoy the grandkids more. And then another thing that was kind of interesting is that people basically don't have insurance for the most part in India. I think only about 5 to 10% of people do. So if somebody gets cancer, it's a pretty financially devastating disease for them, which was really a learning experience for me. Also, kind of the typical things we see here, such as lack of transportation, lots of burden on the caregivers. You know, people don't have Family Medical Leave Act where they can take time off. They just don't get paid if they have to stay home and take care of their relatives, and then depression and other side effects. So the other kind of barriers that were really interesting were kind of from a cultural standpoint. So there's a lot of use of like herbal and alternative remedies. And so people were, you know, here people tend to use them a lot with their standard meds, but there a lot of times people would really be trying to treat with those herbal meds, which stands in the way of getting them to the more curative treatment. And that's probably partly developed because people don't have a lot of money, and those things are probably very inexpensive to access, you know. There were also a lot of negative religious beliefs out there about cancer, such as cancer, you know, getting cancer was something maybe they did in this life or in a, you know, in a prior life that caused them to get cancer. So there's almost kind of a shame factor that's involved with having cancer, and people don't really want to talk about it sometimes. And then, you know, another thing that gets really difficult is the relationships, because when you look at the hierarchy of families and all, basically with not a whole lot of money available, people have to make decisions on whether they're going to access cancer care for their family member, and that might partly rely on whether they are older versus younger. If they're younger, they have lot more years still working in the system. People have to make those kind of decisions sometimes, which seemed like it was really, really hard. Finally, lack of trained professionals and cancer clinics in the rural areas. Obviously, that's why they need the navigation program, because there aren't any local services available. So the other thing is that lack of morphine availability in the villages. So morphine, you know, is basically grown, you know, opium in India, the biggest source of it, but the difficulty, and it's very inexpensive in India, but it's tightly controlled. So for people living in rural areas, they would have to go in kind of on a weekly basis to get a new supply, and they do that obviously so that people don't end up becoming addicted to it, but it makes it really hard for people to get care who live out in the countryside. So some facilitators were just incredible family and caregiver support. What I kind of saw was that with having less curative treatment, the focus was a lot more on care, like brushing their relatives' hair and just sort of, you know, really just being affectionate and kind with their relatives and just kind of taking care of them, you know. Also, family participation in decision making. So families tend to make decisions about cancer treatment and how that's going to go and whether folks will get it, which kind of can be good and bad. And then the other facilitator is that even though people don't get to the cancer center until very late stage, once they get there, they tend to really love the oncologists at this particular cancer center, who are just incredibly passionate people that are. The cancer center was actually developed. I'll tell you, it started from a basically Dr. Suraj Gupta had noticed that people coming to the city centers to get cancer treatment, and they didn't have insurance, so they couldn't get into the system. And so he kind of first developed just a simple home to care for them and let them, you know, kind of rest in dignity, you know. And then little by little, they did such a good job with it. It kept building, and they started bringing in some, different types of services. So now it's like a full-blown cancer center. It refuses to take any money from the Indian government because it doesn't want to be involved with any kind of, some of the bureaucracy and the favors and all that go along with that. But they've done a really nice job. And so once the patients get there, they love this cancer center. So in terms of also doing our study, the provider team at the cancer center was just phenomenal. They, we were able to get 22 qualitative interviews scheduled and done in just an incredibly short period of time. And they really believe kind of in the research model and want to be able to see this tested and to see it make a difference really in other places in India as well. The other thing that I thought was really interesting was, I don't know if anybody has heard of the barefoot doctors from China. So the idea there is that people live very, very remotely, and they couldn't really access services. So they trained up a lot of people that just had some basic medical knowledge and skills, and those people would then deliver care in their communities. Well, kind of the same system evolved in India, and these folks already work out in the community, and so they already have systems for billing the patient, which are, basically, give me your $1.50 kind of thing. It's very, very, very low cost, especially compared to what the cancer center would cost. So we'd initially thought about using volunteers, but we're like, these guys already have systems that seem to work, and they want to kind of uptrain themselves to get a little bit more respect in their communities. And so it just seemed like a very natural fit. And again, the morphine is free, so the cancer center is able to provide it for free to their patients, but they just have to come and get it, which is challenging. So the needs were, there's no funding really to support cancer treatment. Home-based palliative care is needed 24/7. Access to morphine needs to be simplified a little bit for patients, because we were hoping that we could have like someone in the community hold stocks of morphine for the patients, but there was a lot of resistance by the other providers at the, in the community there, worrying that it might end up getting out of control and causing people to become addicted. So there'll need to be more work on figuring out those systems. But for now, we'll just use the navigator to kind of run back and forth on a weekly basis to town to get the morphine for the patients. And then obviously education about the patient's condition seemed like it could make a huge difference. So aim 2 of the study, we're working now on putting together the intervention that's based on the World Health Organization toolkit, and lots of good information that we got from the interviews. We are basically tailoring the intervention to the patient and clinical preferences, culturally, spiritually, and financially. The intervention strategy, again, we were first going to go with using community volunteers. But the more we learned with the system, this whole infrastructure with sort of the barefoot doctors in place, it made a lot of sense to go with people that are already kind of working and have the relationships in the community. And I'll just say as an aside, some people call them barefoot doctors, others call them quacks. So that's the kind of edgy part, is that because they're not formally trained as doctors, they tend to be picked on a little bit, but this tends to happen a lot in developing countries where they're kind of looked down on as the lower brethren of clinicians. So that's one little issue, but I thought it was pretty insightful that the cancer center oncologists were just willing to try out this type of system. So we'll basically train the barefoot doctors to serve as navigators, establish the support system and communication channels between the doctors and the oncologists. Focus a lot on patient and caregiver education so they understand the illness better, and work with policymakers more long-term to improve access to opioid medications. So for AIM 3, testing the feasibility, we're basically just recruiting 6 navigators in the 24 Parganas region, which is where the intervention is taking place. And we will basically do about a week-long training with them. We'll develop the training. One thing that was interesting, originally Suparna and I thought, well, maybe we need to really go there. But the people at the Cancer Center have such incredible expertise in their respective areas. They work clinical psychology, oncology, palliative care, that we could never even hold a candle to what they're doing. So they will deliver the intervention. We will work with them on putting it together, but we'll just basically join by Skype for the actual training, because they are wonderful. And then for AIM 3, we'll test the feasibility of the intervention with a very small number of patients initially, about 15 patients in that area. Each patient will be assisted by a navigator, and the patient and the navigator will meet with the clinical team to get the kind of intervention started up. And then from that point, the navigators will go out to the patient's home at least once a week to facilitate very basic care. Again, serve as a link between the patient and the cancer center, manage pain and symptoms, help find resources for services they might need, and facilitate emotional support. Data collection will mostly focus on basically the process. basically looking at the navigation training outcomes, what are the roles and the tasks, what are the things that the navigators can do, what are the things that they aren't able to handle so well. We'll also start testing out some patient and health level outcomes for use in a larger trial, and also look at stakeholder satisfaction kind of from everybody's perspective to see what they thought of it and what needs to be changed. So in conclusion, the study is designed to improve palliative care for patients in the rural areas. The current services that they do now where they send out the team requires a lot of resources, which just isn't going to work for them in, out in the more rural areas. And lay navigators seem like a really good concept for being able to help expand the reach of services and maximize the use of scarce resources. So if effective, we will go on to evaluate the intervention in a randomized trial. And then especially on the Indian side, it's incredible the extent to which the people at the Cancer Center are really ready to take this, bottle it, and push it out further in India. It's, we think of the research cycle here takes so many years. I get the sense that if we test this thing, it'll go out a lot quicker because it's something that they really need and it's not really been looked at before. So I just wanted to thank the project team, the folks at MUSC. We have some amazing students working with us, one of whom is here today, Kirti Advani, and a PhD student I'm working with, and another College of Charleston student. We also met this incredible lady when I was at the APHA conference, Shibani Ray, who is the most amazing clinical psychologist, and her husband is from the